So there is medication. Again, we start first with the food, but when we talk about medication, we're looking at physiologic medication that really mimics what the body normally does. And specifically in type 2 and pre-diabetics, we have these newer medications. I again explained about the GLP-1 and the amylin mimetics, Byetta, Victoza, and Similac are, to me, revolutionary drugs. They're smart hormonal drugs that basically affect every aspect of the cascade that we were talking about. Metformin's an older drug that we've used in diabetics that has a slight effect on weight loss. There are, of course, the appetite suppressants, but that's not the primary focus of what we do here. And then there's the future, and that holds a lot of promise. There's over-the-counter market, and just to say, you know, there may be some good and definitely some bad things there. We're going to treat the comorbid conditions, and of course, you know, I have my arsenal of medication, which I still use when I need to, but what's important is to understand that these conditions are all connected, and it's a new approach where we're treating inflammation. We're not treating the cholesterol independently, the hypertension independently. We're treating it all as one. And it brings us back to the lifestyle, which does address everything. And then, of course, there's bariatric surgery if all else fails. But the point here, what's interesting is that when you do bariatric surgery, the GLP levels go sky high, so it does something very interesting to the hormones to suppress appetite. So we want to teach our patients how to focus on the carbohydrate content of food, and so we have some tools. And so the first tool is the glycemic index. What is that? That's the measurement of a food's ability to rapidly raise blood sugar. So foods that have a high glycemic index are bad. Now, unfortunately, it is not on the food label. Maybe it will be in 10 years. But what you can do is print out charts. On my website, and I have a reference to it at the end, I have 3 or 4 glycemic index charts, glycemic load. I have too much information on my website if you're interested. But so basically, this is actually a revised guideline, and the reason it's revised is the glycemic index guideline came out in 2002 from the University of Sydney. They're the people that invented this. And they weren't really thinking about carbohydrate restriction like the way I think about it. And so they initially say that foods that have an index under 55 are healthy. And I'm saying that that's too generous. And so I have my patients focus on foods that have an index under 30. And we basically break it down into thirds. And I don't have time really to go into it much more than that. Then we have glycemic index, which is really the glycemic load rather, which is the glycemic index times the grams of carbohydrates. And so the point there is that watermelon, for instance, it actually has a high glycemic index, but it has very little sugar in it. And so therefore it would say, well, okay, you know, based on glycemic load, watermelon wouldn't be that bad. And if you want to focus on glycemic load, you can, but my issue with it is that glycemic load allows you to eat more foods that you would otherwise not eat if you focused on glycemic index only. The next tool is carbohydrate gram counting, and the point here is that the more you restrict carbohydrates, the more rapid your weight loss will be. Now, I actually added this because Susan, again, had me made some comments about what the American Diabetes Association is doing. And they, in 2008, have recognized that carbohydrates are an issue, and that's great that they recognized it. And what they said is that, as a start, we can restrict carbohydrates down to 130 grams a day because they're afraid to go lower. But this is actually a start for my patients. In other words, if I have patients maintain weight, I usually start at 120 to 130 grams of carbs per day. The ADA uses what's called the food exchange, which is interesting. The basis of it is first the carbohydrate content of the food. Then they look also at fats, calories, and they're really, still are using this concept of balance. And I look at it that they have a lot of pressure from all over the place in terms of coming up with nutritional guidelines. Now, in my office, I have the ability to go off what the official guidelines are. And so I think that it's good, it's going in the right direction, but it still needs a little bit more work. But then again, we break it down into 3 levels of carbohydrate restriction, and under 40 to 45 grams, which you might consider extreme carbohydrate restriction, but I don't like to use that term because this is where you have to be to help patients lose weight. Because again, carbohydrates aren't healthy. But as you further restrict carbs, it causes rapid weight loss in this concept of healthy ketosis. And this is the state where the body is just burning body fat so fast that it releases ketones. And this is in contrast to diabetic ketoacidosis, which is an unhealthy state where insulin levels are sky high. The body is not responding to insulin, and it's just burning body fat, and it's an unhealthy state, as opposed to healthy ketosis, where sugar levels are controlled. We're restricting carbohydrate consumption, and we're burning body fat in a healthy way. And again, what's important for our patients to understand that the quantity, calories, and portions are less important. What we're trying to do is regulate insulin, not the calories that we consume. Again, another fundamental concept that we're saying is a little bit different today. And we're trying to help patients lose weight by eating versus starving, or not eating. So, evaluating diets, and what we want to do is compare the macronutrient contents in the diet. And at the 2 extremes, we have the very low-fat, high-carb diets, such as Pritikin and Dean Ornish diet. On the other extreme, we have the very high-fat, very low-carb diet, the Atkins or the Bernstein diet, and then we have everything in between. I have a link to a tool that you can plug in different diets, and it gives you the percents of macronutrients. Now, some patients are interested in that. As a healthcare professional, I'm very interested in it. So I like to compare diets like that. So what diets are healthy and safe? And so we support anything that works, and we want to monitor our patients. And so what's the message here? And the message is that low-carb diets improve health. And by that, I mean that the markers of inflammation improve. And we have many studies, and I've mentioned 3 in the last 10 years, that are randomized, well-controlled studies comparing diets that demonstrate this. And so this is the Diet A to Z study, weight loss study, that, again, a randomized trial from Stanford. That was the first one that I mentioned. And so they looked at 4 diets. We have, on the low-carb side, we have Atkins, then it goes to Zone, Learn, and then the low-fat is the Ornish diet. What's interesting is that this was a group of 250 women that they studied over a year, which is a short period of time. And everyone did what the diets were telling them to do. So these 3 diets here were really calories consumed, played into it, and so the patients had to monitor their calories. Whereas Atkins was low carb, and traditionally they tell patients to eat until they're full, but they're not regulating calories. So what happened is that the calories consumed were equal. Everyone started eating at the beginning. Before the diet, they were eating more calories. As they went into the diet, everyone ate less calories, but in the Atkins, they were eating all these high-fat, high-protein. They too ended up reducing their caloric intake without even worrying about it. And they were eating all this fat. And you think, well, okay, all those fat calories, will they be eating more calories? No, well, the way the study worked, that calories were basically controlled throughout the patient groups. And what happened is that the Atkins people, on the bottom here, they lost more weight in 6 months than 12 months. So it'd be nice to take this out and go further. So what about markers of inflammation? So, they looked at cholesterol as terms of markers for inflammation, and so what was determined is in the Atkins group is that the HDL went up higher than any of the other groups. Here's the HDL in the Atkins. The orange is at the bottom in terms of the HDL. Triglycerides went way up, or way down rather, 29% reduction in triglycerides, and the other ones weren't even close. Now the one thing that did go slightly up was the LDL, and in the orange you can see LDL went down, and so if you traditionally look at cholesterol, you say, okay, well the Dean Ornish diet was much better because the LDL, dropped. But the message that I'd like to convey is that there's new science in terms of cholesterol, and we have to look at HDL, we have to look at triglyceride. We have to look at a new concept called particle size, where they now break down the cholesterol, they run it through a centrifuge, and now it's the science of particle size, where the fluffy LDL particle A confers a 4 times less risk of heart disease than the unhealthy particle B. And so this study suggested from other studies that they were suspecting the particle size went to the fluffy, healthy pattern A. And they're now looking at statin medication and low-fat diets, looking at particle size. And unfortunately, it looks like it doesn't have that great of an effect on particle size, whereas the low-carb diets do. And to illustrate that, this is from another study, and I would just refer you to the bottom of the slide. And as the triglycerides drop, LDL particle size increases. So it's just a normal physiologic response. And this just shows VLDL is basically what carries triglycerides. So VLDL drops as triglycerides drop, but particle size increases. And so the more and more I read about cholesterol, the more and more I'm confused, and more I read and I try to understand it. So I think lipid science is evolving. And what I would say is in the majority of our patients that we put on low-carb diets, some of the guys have to go. See ya. So the majority of the patients that we put on low-carb diets, we actually see LDL drop. There are a few patients where the LDL does go up, and those are the patients where I check particle size. The other ones I don't even bother. But we see it increase. But what's interesting with all those patients that have their rise in LDL, all the markers of inflammation drop. So every marker, their cardiac CRP, their HDL, their triglycerides, their diabetes, their high blood pressure, everything gets better. And yet sometimes the LDL goes up. So, I struggle. Well, what does that mean? Does that mean we're doing something unhealthy or healthy? So just one parameter goes up, which traditionally was thought of, we think of that as being an unhealthy thing. And my answer to it is there's more to it. We don't quite understand it. Okay, so we're almost finished. Let me just go to patient number 2 is a female. She's been my patient for years, and she comes, we've been treating all her medical problems, hypertension, obesity, depression. She's on some medications. We do her OGT, and we actually do a 1 hour, and it's not clear what the normal is, so we use a cutoff of 180 for a 1 hour. I know in pregnant people they use 140, but for normal population. So this one's high, this one's high, over 140, so we call it prediabetes. Her A1C is not terrible. Her cholesterol is high, not bad. Her HDL is good. Let's see, her LDL, whether or not that's up or down, total cholesterol might be a little high. And she meets this criteria for metabolic syndrome. So we treat her with carbohydrate restriction and some supplements. 3 years later, she loses 90 pounds, 31% of her body weight is lost. We repeat her OGT, and it gets significantly better. Is she still insulin resistant? It's just a matter of what you consider the cutoffs to be. Her A1C drops, and her triglycerides, her HDL goes up, triglycerides go down, just like I showed you on those studies, and her LDL drops in this particular case. And she's maintaining her weight loss, and she still needs to lose some more weight.